It's such a pleasure for me to be here, and I was commenting before that I'm surprised I've never been at this forum before, because I've been part of the Kidney Cancer Research Network for many years, and I've met many of you lots of times, so it's just fun for me to be here. So I was asked today to talk to you a little bit about survivorship and sort of some programming that we're doing at Princess Margaret, but that I'm also aware of there's other resources that I'm aware of as well that I'd like to highlight. And I'm the director of the Cancer Rehabilitation and Survivorship Program at Princess Margaret Cancer Centre. So I'll tell you a little bit about what that looks like for those of you who are interested. So you all know this is nothing new to you, but I like to sort of set the scene about how we know the incidence rate for kidney cancer has increased significantly over the past decade, maybe not as much as some of the other cancers, but mostly this is just really due to sort of improvements in imaging technologies, so that those incidental findings, as well as increase in obesity in our population, which is, and hypertension and smoking, which are all related to the incidence of kidney cancer. But we also know moving forward that incidence is likely to continue to increase because we have an aging population and also a growing population. And so we will likely, the projections are that this will continue to increase, especially in men. The good news is that mortality rates overall for all cancers really have dropped, and this is true for kidney cancer too. This is due to many different factors. Probably the most important factor is the fact that we can detect kidney cancer earlier, and we have much better and more targeted treatments for kidney cancer. So on average, about just over 65% of patients can expect long-term survival. And patients who have localized disease, where their kidney cancer gets caught fairly early, the survival rates are over 90%. So that is a good news story. But what I like to highlight is that there is always a cost to survival, and we always celebrate survival, but we also have to think about sort of the disease process or the cancer and its impact on people's lives post-treatment as well. Because our cancer systems have historically and continue to be really funded and focused very much on the acute phase, the treatment phase, and we haven't really put a lot of effort or thought into sort of the recovery and survival and post-treatment phase. So cancer is a little bit different, and we've started to think of cancer as sort of a chronic disease a little bit because people are getting cured, but then they're living for many years with sort of side effects, persistent effects, late effects. But also people have metastatic disease for many, many years or intermittent disease where their disease will come back and then they'll get a treatment and then they'll be good for a few years and then they'll come back. So we've heard all those stories today. So it's very similar to some other chronic diseases. But unlike other chronic diseases like diabetes or arthritis, where disability is actually caused by the disease processes itself, with cancer, it's actually the treatments that we give to people that cause the disability. And so I think that's really important for us to think about. Now, we know that most of the treatments that we give to people, and you're probably all familiar with these, can result in acute side effects, which happen during the treatment phase. So most people, when they're undergoing chemotherapies or when they're recovering from surgery, will have fatigue, some pain, those types of things. For some people, for a lot of people, those things will go away once that treatment ends. But for some people, for some reason, we don't necessarily know why, it's fairly complex, some of those side effects don't go away. So we know, in about a quarter to a third of patients who develop fatigue during treatment, that fatigue for some reason just doesn't go away, and they can have it for many, many years, up to a decade after treatment ends. These side effects can certainly impair people's ability to get back to work, to see their families, those types of things. So those are called persistent treatment effects. There's also something called late treatment effects, which are side effects of the treatments that you take or get that sort of come up many years later. So you're going along, you're doing fine, and then all of a sudden a new side effect comes up sort of out of the blue. We know, as I said, we can't really predict who's going to get these, but we do know that they can be complicated by pre-existing risk factors. So people who are older, people who have other comorbidities, which many people who are diagnosed with cancer are diagnosed and already have other comorbidities when they're diagnosed. Their genetic risks, and then behavioral and lifestyle factors, as Linda talked about, people who are obese, people who are sedentary and not physically active, these things can be exacerbated. There was a study that was published back in 2014. It was a cross-Canada survey that maybe some of you participated in. And in this study, it found that the majority of patients, this is of kidney cancer patients, experienced negative physical, psychological, and emotional impacts as a result of their experience with kidney cancer. So these are quite prevalent. And what I think is interesting is that about a half said they were not prepared to deal with these concerns. And this is something we hear very often, is that people aren't told about what late effects they could expect, how is it normal to have this fatigue lasting for so long, how do I deal with these things? So they sort of come out of the blue and they're not really feeling prepared for those. So just in terms of physical effects and well-being, I mean, anybody who's had a diagnosis of cancer and kidney cancer is always at risk for recurrence, but also there's risk for second primary cancer. So I think our health system does a fairly good job of surveillance for that. So you go back to your oncologist and you have your scans, you have your, at either 6, 9, a year, whatever your surveillance plan is, and that's what they're looking for. We also know in terms of long-term late effects, there's chronic kidney disease, cardiovascular events, osteoporosis, pain, fatigue, sleep disturbances, all these things that I'm sure many you're very familiar with, and certainly with the adjuvant or systemic therapies, there's lots of other side effects that people can experience physically. But there's also, as was discussed in the last panel, psychosocial issues as well, and psychosocial well-being that's really important too. Patients and their families and caregivers face very significant psychosocial and also economic and financial consequences of their disease. I would say in cancer survivors, people who are post-treatment, one of the most common issues that people struggle with is the fear of their cancer coming back, so that fear of recurrence. For some people, it becomes actually quite debilitating. It becomes all-encompassing. So it's very normal for somebody when they're coming for their checkup, for their 6-month or 9-month appointment, to start feeling a bit anxious going into that appointment that their cancer's coming back, that they'll find something. I think that's a very normal response. And for some people, though, they think about it all the time, and it becomes really overwhelming. And that is actually a substantial proportion of people that have that. And there are ways to help people with that. That's not that you shouldn't just accept that as a norm. There are people that can help you with that. Lots of people talk about this feeling of uncertainty, of feeling angry, anxiety, emotional vulnerability. There's issues around altered body image, feelings and impact on sexuality, and changes in social outcomes. People often talk about how it's changed their relationships, and these are important things. Their community involvement and how they socialize. And then obviously there's lots of practical issues for people. Getting back to work after you've been off work, or going back part-time, or whether you need to retire or not. There's issues around employment and insurance implications, and also the financial implications and issues as well. We do have a social healthcare system here where our treatments are covered, but as all of you know, there are lots of out-of-pocket expenses for people. And when you leave work, if you don't have a long-term disability and those types of things, there's huge financial implications of that. I've sort of set up this presentation where I'm going to take a break in the middle just so we can have a discussion, because Stephen suggested that I do it that way. So I wanted to just highlight this survey that we did a couple of years ago, and I think it's maybe being presented at this forum before, but I wanted to pull out just a couple of the things that sort of highlight some of this background that I've given to you. So this was a cross-Canada survey that we did looking at information, support, and treatment access needs of kidney cancer patients. Really, we wanted to, I'm not going to talk about the treatment awareness and choice and barriers to care, because that was sort of a separate objective, but I did want to just highlight the supportive care, unmet needs, and access to information preferences for patients. So this was a questionnaire. It was a cross-sectional study, so people were just asked to fill out a questionnaire at one time point, and it was available in English and French. We did it across Canada. People could do it online, or there were some surveys in a few of the larger cancer centers. And we had just over 360 patients complete this, which is a great sample size, nice and big. And people were at all stages, and also, again, cancer journey, I like to say trajectory too, but you know, some people were on actually recently diagnosed and just starting their treatment. Some people were having active surveillance. The larger majority were sort of post-treatment in their follow-up phase, and then there was about a quarter that had either recurrent or metastatic disease and were having treatment for that. What I thought was really one of the really interesting findings is this, was we asked people, when you're first diagnosed with your kidney cancer, did your doctor discuss any of the following with you? And it looked like the doctors did a pretty good job of describing the specifics of the disease and general information about that and their prognosis and the different treatment options. But where people were saying they weren't really getting a lot of information was where to get information and support, and also access to treatment and cost. And these, as we know, are really, really important issues for patients. So I think this is something, and we've heard that from the panel, are things that you should be asking for because they're important. This is important information for you. So we asked about supportive care needs, and there's a questionnaire that we use that's very commonly used, and it has a list of about 40 different supportive care needs, and people would just rate whether it was a need for them or not, and whether it was met or unmet, so if they'd gotten services for this or not. And so patients had a sort of an average of about 4 unmet needs, which means they identified it as a need, and they identified not getting any help for it, that it was unmet, it was not supported. So in terms of just overall whether they said it was a need or not, and whether it was a need and whether it was met or not, the most important supportive care needs for this population was, I feel like I'm managing my health together with my medical team, that I want to get the very best medical care, and to know that all my doctors talk to each other and coordinate my care. So these 3 items I don't think would be any surprise to anybody, and the good news is most people said that this was met. So, you know, and this is all around coordination of care and getting good medical care. So most people said this is a need, and it's been met for me. But where we talk about, when we asked people about what their unmet needs were, they really got into sort of more around the coping and the things. So help to cope with others not acknowledging the impact that cancer has had on my life. I would say this is definitely an issue when people are post-treatment. They kind of feel often that, oh, I'm done, you're done your cancer treatments, everything's done, life goes back to normal, but the patient doesn't feel that way, and they still feel like they need support, and they need that acknowledgement that they've been through that. You know, people often talk about this idea of having a sort of a case manager, or, you know, we've heard from our last panelists, often we have these great nurses that work in our bigger centers that can sort of act as that, a person that you can call that can help to coordinate things for you. So, but that's not often available. I mean, having those types of nurses is not available in every place. And this idea of uncertainty, just people needing to make decisions and needing support in this sort of context of uncertainty. We did find there was a greater number of unmet needs in younger people and amongst women, women versus men. And in the northern region, so like the Yukon and Northwest Territories, and in Quebec, they had higher unmet needs. And those people who are newly diagnosed and currently receiving treatment had higher needs than those who were in their post-treatment follow-up. Not surprising, I don't think. Most people received their information about their kidney cancer from their urologist or their oncologist. Many got it from the Kidney Cancer Canada website or on the phone with them, through their family doctors or through other websites. And they found that the most helpful information was from their medical team, or the urologists or oncologists, or from Kidney Cancer Canada. A lot of people like to get information from the internet, and most people were very comfortable getting information from the internet. So I just want to talk a little bit about survivorship care, and as I said, it hasn't been in our healthcare system an area or sort of a focus, because we've been very much focused and funded for the acute care and the treatment phase. And so back in 2006, the Institute of Medicine in the States did a study and came out with this report called From Cancer Patient to Cancer Survivor Lost in Transition. And so really in this report, they just highlighted that survivorship care and post-treatment care is a very neglected area. And that there are a lot of issues that patients are dealing with. They're unaware of their risks. They're not really sure what their follow-up care looks like. Cancer care is often not coordinated post-treatment. And part of the problem with that is that we don't have a lot of guidelines and sort of evidence in terms of what follow-up care should look like. So that's been a bit of an issue. But they did come out these essential components of what survivorship care should look like. So certainly surveillance is very important. As I said, I think our healthcare system does a really good job of that. You come for your follow-up appointments, you get surveilled for cancer spread, recurrence, or second cancers. We also should be, I think, focusing a lot on intervention. So people who do have persistent or late effects, we should have interventions and services to address those. Where we probably need to do the most amount of work is around coordination. There are lots of different people involved in care. You may have a cardiologist, you may have an endocrinologist, you might have, your family doctor, and then you have your urologist. And all these people, we need to coordinate care a little bit better. And then certainly prevention. We don't do a great job of preventing cancer to start with, and we don't do a lot in terms of secondary prevention, around prevention of persistent late effects, but also prevention of cancer recurrence or secondary cancers, and I think we could work more on that. But these are what they recommend are essential components of survivorship care. So in terms of finding support, I just want to sort of switch gears and talk about where you can find support for during the survivorship phase. So certainly it was highlighted before with our panels. Most of the hospitals do have some support available. They have psychosocial or supportive care services available during treatment. I know at our center, Princess Margaret, that's available up until about 6 months post-treatment, and then you don't have access to that anymore. So that's a problem for people who maybe a year out feel like they need some support or help, and that's where our program comes in. But there are also lots of great community-based support programs. In Toronto, we have Gilda's Club. There's also Wellspring, which you can find in, I believe, in many different centers in Ontario, and as well as in Alberta. And I know in Quebec they have also Hope and Cope, which is very similar to Wellspring. So there's lots of great community-based programs and centers where you can go and you can get programs there. There's also lots of online resources, so Cancer Care Ontario, Canadian Cancer Society, and there's a program called Cancer Chat Canada where you can go and they have, so if you're in a rural community and you want a support group, you can go and register, and it's an online support group that you can register for. But obviously, Kidney Cancer Canada has developed a lot of really fantastic programs as well. There's the peer support program, the discussion forums, there are these wonderful patient meetings like this, and then there's a number of educational resources that you can access. So just to finish, I do want to highlight what Linda was talking about, and I really, really want to stress this idea of physical activity. We know that it's safe. It reduces risk for lots of chronic diseases. It improves people's kidney function, cardiovascular function, blood pressure, energy levels, all these things. But we also know that the majority of kidney cancer survivors are not meeting the guidelines for physical activity. So I would encourage people to just, as Linda said, that guidebook that Linda really worked very hard to develop is a fantastic resource. Grab it when you go out. It gives a very practical way to start your exercise program. And within the hospitals, too, there are often resources that can help you. And I'll talk about what we do. And this has sort of led, this whole push towards physical activity and getting and managing persistent late effects has really started to, out of this, has a number of people have started to advocate for cancer rehabilitation, which actually, cancer rehabilitation, there was sort of a movement towards this in the 70s, and it sort of never gained any ground, and it's starting to gain ground again now. But the idea is that cancer rehabilitation are programs that really can address some of the survivorship care gaps that occur with focusing on specialized physical and mental health recovery. And I don't know if any of you have heard of cardiac rehab, but if you have a cardiac event here in Ontario, you automatically get referred to a cardiac rehab program. And it's the same idea. So once you finish your cancer treatment, you get referred to cancer rehabilitation. Now, not everybody needs this. A lot of people do quite well, and they don't need that at all. So the idea is that you triage those patients who actually need those services to cancer rehabilitation. And it doesn't actually have to be people who have finished treatment and have no disease. People who have metastatic disease or intermittent disease can benefit from these programs as well. So the idea of cancer rehabilitation is really, it's focusing on physical, social, vocational, and psychological functioning, and to help people to really obtain their maximum functioning within whatever limits they are dealing with as a result of their treatments and their disease. So at Princess Margaret, we rolled out a cancer rehabilitation program a few years ago. Actually, this program started in the breast and gynae and head and neck sites, and then 2 years ago we rolled out to all disease sites, so it's available to all the different disease sites at Princess Margaret. And we have a very multidisciplinary team. It doesn't show up that well, but we have a physiatrist who's a rehabilitation medicine specialist, as well as fellows. We have physiotherapists, massage therapists, a dietitian. We have neuropsychologists that helps deal with the cognitive changes that people experience as a result of the chemotherapies, occupational therapists, a social worker, and a team of kinesiologists that do the exercise programming. And our focus is really on, again, just the cancer rehabilitation, the idea of getting people to maximize their quality of life and their functional independence. And I can answer more questions about this, but really the main program within this, we have a number of one-on-one consults that you can have with individual members of this team, but the main thing is an 8-week cancer rehabilitation group program that people can come through, they can get referred to, and they go through 8 weeks of learning how to get physically active, working with a kinesiologist to develop a very personalized exercise prescription that then gets ramped up. And then each week they get, they meet with a different, their group meets with a different healthcare professional that talks about different topics like managing fatigue, learning skills on relaxation and managing distress. We have a kitchen in our center, so one of the sessions is on nutrition. Learning how to develop social connectedness and supporting yourself and your caregivers and those types of things. So each week is a different topic. We have found that about 40% of the patients that we've recommended go into this program are not able to because they're traveling from very far. You know, we have some people that are traveling many hours to come down to see their oncologist, urologist. So we are launching in this summer, early fall, an online 8-week cancer rehabilitation program, which mirrors basically the in-person program. So you would come in and you get your assessment in person, but then you'd go home and do the 8-week program from home, supported by our team remotely. So we will be launching that hopefully soon. And I just want to finish by, this is a great resource that we have developed. We have a kitchen. I don't know if any of you have heard of the Elixir Centre, but this is a cancer rehabilitation center that we have at Princess Margaret. It's a 12,000 square foot research center that has a gym and kitchen and everything like that. And in our kitchen, we have a wellness chef as well as a dietitian. And they develop amazing recipes. I think we have almost 400 different recipes in the kitchen. So if you look at online, it's elixirkitchen.ca. We have a YouTube channel as well with all of our videos, so you can watch the chef make the different recipes. We live stream every month. We do a live cooking demonstration that you can come to, or we live stream it as well, so you can participate that way. And you know, some of our videos have over 1 million hits. They're very, very popular, and that's available to anybody around the world. So there's lots of great resources there on how to read nutrition labels, and also lots of different things like that, and also different great recipes. I actually go to this website all the time when I'm having dinner parties to get recipes because they're so great. So they taste good too.
Jennifer, if we do not go to Princess Margaret or any of the UHN hospitals, are we allowed to access Elixir, and how might we do that?
So some of the wellness programming, the kitchen classes, anybody can drop into those. We have some programs that are drop-in, but right now, most of our programs are restricted to Princess Margaret patients. The reason why I like to highlight it, though, is I think it's something that we should all be advocating for. I think these programs should be happening everywhere. And, you know, everything that we do, we try to share with other centers, and we try to advocate for that. So I go to Queen's Park and I advocate for funding for cancer rehab and to build these types of programs. I build an evidence base around the outcomes of these to be able to then advocate that they're impactful, that they, you know, reduce costs and improve people's quality of life, so that we can then get funding so that other centers can have it.
And thank you for your great work.
Thank you, Jennifer. Thank you.